Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/tnj. This activity is supported by an educational grant from Bayer AG. Bayer AG has had no involvement in the selection of the speakers, the development of the activity, the agenda, or the materials.
Good afternoon and welcome to this CE Educational Symposium titled Assessing the Potential of Factor XIa Inhibition for Secondary Stroke Prevention, Supporting Our Cross-Specialty Colleagues in Improving Patient Outcomes. Before we get started, please make sure that your cell phones are in silent or vibrate mode. This event is being recorded. I'm Jeffrey Weitz. I'm a hematologist in Canada, and with me I have two expert neurologists, Charlotte Cabanier from France and Mike Sharma from Canada. I'd like to thank Bayer AG for providing the educational grant for this CE accredited activity and Peer Voice for organizing this symposium. Okay, so let's move on, and Charlotte is going to talk to us about the rationale behind Factor XI inhibition for secondary stroke prevention. Can we prevent thrombosis without affecting hemostasis?
Thank you. So hello everyone. Bienvenue à Paris. I will not do it in French, for sure. But let's go and let's dive into the world of stroke. So the majority we are really dealing with in terms of causes of ischemic stroke are not the cardioembolic stroke. We all know about it, but it depends on the age of the population, but it's roughly a third of ischemic stroke that is linked to AF. I will talk about the other 2/3. The one that are associated with atheromatoous disease, and also the last third of ischemic stroke that are due to small vessel disease, so very small penetrating arteries that are filled with lipohyalinosis. So we are really focusing on non-cardioembolic stroke. And when you suffer from an ischemic stroke, of course, we, as neurologists especially, we focus on thrombolysis, mechanical thrombectomy, and we know that we are saving life and that we are reducing dependency. But for the patient perspective, when they are discharged from the hospital, they really remain with a lot of anxiety about the risk of recurrent stroke. And the risk of recurrent stroke is not as low as we may expect. Here are some data. It's roughly around 6 or 7% of risk of recurrent ischemic stroke during every year after the first event. And those are numbers that come from patients who are discharged from stroke. So we do not take into account the acute high risk of very early recurrence. So when you're out of the hospital after a first ischemic stroke, non-cardioembolic stroke, your risk of having a second stroke is roughly 6%, 7% every year. And of course, when you're suffering a second stroke or a third stroke, the risk of dependency and the severity of a stroke is much higher. So this is really something that we need to decrease. And up to now, it's really one of these unmet clinical need that we have to solve. And we have the experience that we can reduce the risk of recurrent stroke, but it always come with a cost. And when we use double antiplatelet therapy, for example, we know that in ischemic stroke patients, we can only do it during 21 days because after that, we pay the price of hemorrhagic events that is too high compared to the benefits. And of course, stroke neurologists, we always try to do what the cardiologists did a few years before us. But there's one major difference, is that the heart do not bleed. The brain may bleed. This is why our benefit risk perspective is totally different when you're dealing with the stroke world. And we are basing our thinking on this concept, which is when you decrease the risk of thrombosis, you have to pay the price of a major bleeding risk. And in fact, maybe we are wrong, and maybe there are other strategies. So I suppose that here you do not need any explanation, because I'm the neurologist and you're probably much more expert in this cascade. But what really we have on one side, the hemostasis cascade, on the other side, how we deal with thrombosis. And maybe just to show that as a neurologist, we really are focusing on the content and also on the vessel. And you can see that when there are small holes in the vessel because there's a chronic vessel disease, we may be at risk of bleeding, because when you kill the hemostatic cascade, you are not able to fight against bleeding anymore. And this is the old concept. This is why we pay the price of bleeding. But of course, we have now the example of a direct oral anticoagulant that showed us that we can selectively target one crossroad or another in this hemostatic cascade. Still, when we target the crossover around factor 10 or around thrombin, we still pay a price in terms of bleeding. Very interestingly, before this crossroad around factor 10 and thrombin, there's this factor 11A story. And we know that if we can just target this factor 11A, we will preserve the hemostatic action, but we will enhance the prevention against thrombosis. And it's not only based on biological data, it's also based on epidemiological data. So we know that some patients have congenital deficit of factor 11A, and those populations have a very low risk of thrombosis without having severe bleeding. And we also know that when we compare population with high level of factor 11A versus a population with normal level of factor 11A, those patients with high level of factor 11A have a twice higher risk of thrombosis. So we also have data from epidemiological perspective. We saw the theory, we saw which patient we are dealing with this strategy, and now we will see data from a large clinical trial. And I'm very happy to hand it over to Mike.
Thank you so much, Charlotte. Hey, bonjour à tous. I've now exhausted my French, so I'll continue in English. So it's a delight to talk to you about the OCEANIC-STROKE trial, the results from the first large phase 3 trial completed in this space. Now, so this is the design of OCEANIC-STROKE, which was a trial we undertook to test the efficacy and safety of asundexian, 50 milligrams once a day, in the secondary prevention of non-cardioembolic ischemic stroke. So we took patients who had either had an acute non-cardioembolic ischemic stroke or a high-risk TIA within 72 hours of symptom onset, and they were randomized 1-to-1 to either asundexian 50 milligrams once a day or matching placebo. Now, all of these patients were on antiplatelet therapy, and randomization was stratified by whether they were receiving dual antiplatelet therapy or monotherapy with antiplatelets. We did not decide on the antiplatelet strategy. That was decided by the treating physicians. Now, the entry criteria for this trial included a requirement for either a non-lacunar infarct on brain imaging, vascular imaging of atherosclerosis. Important to note that the atherosclerosis did not have to be symptomatic, significant, or stenotic. In fact, it could be in the opposite side of the circulation as to the symptoms, or a medical history of atherosclerosis, which could be something like a remote MI or asymptomatic disease. These are the primary and secondary endpoints. The primary efficacy endpoint was the occurrence of ischemic stroke, and the primary safety endpoint was ISTH major bleeding. The secondary efficacy endpoints included the composite of all strokes, ischemic and hemorrhagic, to test whether there was a trade-off, reducing ischemic stroke with increase in hemorrhagic stroke. And the secondary safety endpoints include everything that you might want, including the composite of major or clinically relevant non-major bleeding, symptomatic intracranial hemorrhage, hemorrhagic stroke, intracerebral hemorrhage, which is a subset of intracranial hemorrhage, fatal bleeding, and minor bleeding. Minor bleeding in our interaction with patients during this trial is very important to our patients. It's visible, it causes anxiety, and sometimes makes them stop their treatment. These are the baseline characteristics. The patients that got into the trial, let me start by saying that these characteristics are quite reflective of the non-cardioembolic ischemic stroke population. Most of the epidemiologic data you look at in stroke includes both cardioembolic and non-cardioembolic populations, and there is a distinction. So the average age of participants was 68 years. 66% of our participants were white, but 28% were Asian. The index event was overwhelmingly ischemic stroke, 95%, with the remaining 5% being high-risk TIA. Very importantly for us, we collected all the major stroke subtypes. This included atherosclerotic disease, small vessel occlusion, as well as stroke of unknown etiology. You may be familiar with the term ESUS, which is the majority of this group. The time from index event to randomization was 50 hours. 28% of our participants had hyperacute therapies for their index stroke, either IV thrombolysis, mechanical thrombectomy, or both. The mean NIHSS score, measure of stroke severity, was 2. Important to know that a third of the population in this trial had NIHSS scores of 4 or greater, which goes from moderate to severe stroke. The upper end cutoff in the inclusion criteria was an NIHSS of 15. So this population was much more severe than was included in the dual antiplatelet trials by design. So those trials randomized within the first 24 hours, and as a consequence could not include patients who had been thrombolyzed or had mechanical thrombectomy. Of the antiplatelet therapy that was used, 63% was dual antiplatelet therapy. Now, in current guidelines of post-stroke, this is used for anywhere from 3 weeks to 3 months, depending on the type of stroke and the guidelines you consult. This is the primary outcome of oceanic strokes, the cumulative incidence curves. Asundexian reduced the occurrence of ischemic stroke. The hazard ratio was 0.74. The curves start to separate early, and that separation continues as long as we have data. These are the net clinical benefits that we tested. So for the secondary outcomes, we did see a reduction in the occurrence of all stroke, which is ischemic plus hemorrhagic stroke. There was a reduction in the occurrence of ischemic stroke or ISTH major bleeding, a reduction in vascular death, all stroke, ischemic and hemorrhagic, MI or ISTH major bleeding, and a reduction in all-cause mortality, disabling stroke, fatal bleeding, and symptomatic intracranial hemorrhage. These are the subgroups that we tested, and we tested a number of subgroups which we had pre-specified. I appreciate that there's a large number of them. However, you'll note that the point estimates are all on the left-hand side favoring asundexian. Let me just say that asundexian was effective in all the subgroups that we tried. So effective, irrespective of the age of the patient, effective for males and females, effective across racial categories. The effect size estimate for Black participants is quite high. And if you look at that hazard ratio, it's 0.28. This is most likely due to the small number of Black participants in our trial. But important to note that we did not find any racial grouping where it was ineffective. It was effective whether or not the participant had a past history of atherosclerosis, whether or not vascular imaging showed evidence of atherosclerosis, whether or not there was a non-lacunar infarct on brain imaging. So all of the inclusion criteria were not critical in determining the result. It was effective for ischemic stroke and TIA, with the caveat that there were relatively few TIAs, and it was effective across stroke subtypes. So effective for large artery atherosclerosis, small vessel occlusion, as well as cryptogenic stroke. One important implication of this, as we think about how to apply the results, is expertise in stroke subtyping really won't be necessary to apply these results because we see excellent effect across all subtypes. It was effective whether or not there were hyperacute therapies. It was effective across the range of stroke severity, from mild strokes with NIHSS less than 3 to severe strokes with NIHSS of 8 or more. And importantly, it was effective whether or not the participant was on dual antiplatelet therapy or monotherapy. Now, so not only were strokes less likely to occur with asundexian, but if they occurred, they were milder. We saw a reduction with asundexian of disabling or fatal stroke. The hazard ratio for that is 0.69. We saw a reduction in the need for thrombectomy. Now, in order to receive mechanical clot retrieval, you need to have large vessel occluded. So this is an indication that large vessel occlusion was less common with asundexian. During the trial, our instructions to investigators were that if there was a large vessel occlusion, to proceed without delay to thrombectomy. They didn't need to unblind. It wasn't important whether a patient was on asundexian or not. We felt it was safe based on phase 2 data, and they proceeded. So, and the hazard ratio for that is 0.61. If we look at the group which had more severe strokes and IHSS of 8 or more, there's a 7.4% reduction in occurrence with asundexian. So fewer severe strokes with asundexian than with placebo. This is safety. So the primary safety outcome of ISTH major bleeding was not significantly increased with asundexian compared with placebo. We saw similar rates of ISTH major or clinically relevant non-major bleeding, similar rates of clinically relevant non-major bleeding, and very importantly for our patients, similar rates of minor bleeding. So asundexian did not increase minor bleeding compared to placebo. This is the cumulative function curve for ISTH major bleeding. Those curves are virtually superimposed and there is no significant difference. Now, there is an ongoing phase 3 trial of another small molecule inhibitor, milvexian. This is LIBREXIA-STROKE, and this is what we know of the design. It is a randomized double-blind study, which is currently ongoing in 47 countries. It's estimated to include 15,000 participants. In OCEANIC-STROKE, we had 12,327 participants. The inclusion criteria are slightly different. So patients are randomized within 48 hours as opposed to 72 hours in OCEANIC. And the NIHSS cutoff is lower. It's 7 compared to 15 in OCEANIC. But otherwise, patients in this trial as well are on antiplatelet therapy in addition to placebo or milvexian at a dose of 25 milligrams BID. These are the key inclusion and exclusion criteria for LIBREXIA, which are very similar to what we had in OCEANIC-STROKE. Key differences, so the window to randomize is within 48 hours of symptom onset, as opposed to 72 in OCEANIC. The NIHSS cutoff for stroke severity is 7 as opposed to 15. There is a requirement for objective evidence of acute ischemia by various criteria. TIA criteria for high risk are the same between these trials, an ABCD2 score of 6 or 7, once again receiving antiplatelet therapy. Both trials excluded patients with a prior intracerebral hemorrhage, and importantly, these results will not apply to cardioembolic stroke. So an exclusion in both trials was atrial fibrillation or another cardioembolic source known at the time of randomization. This trial, like OCEANIC-STROKE, seeks to include all TOS subtypes. It goes about it slightly differently, but it does include them. And you see the remainder of the exclusions there. So we're looking forward to the results of LIBREXIA-STROKE as well. Hopefully it will recapitulate what we saw in OCEANIC-STROKE. So I'm going to turn it over to my colleague Jeff Weitz to lead us in a discussion about what we need to know.
Thank you very much, Mike. And now we're going to move on to the third part of this symposium and think about the clinical implications of the data that we've just heard and what do we need to know as members of the multidisciplinary team. And sitting here as a hematologist, I look at it in two aspects. One is the patients, the characteristics of the participants in this trial, and the other relates to sort of timing. There was a 72-hour window. Often patients present outside this window. So what will the window be going forward? How long do we treat? All of these come to mind. So let's start first with perhaps stroke etiology, and then we can move on to bleeding risk. So, Mike, tell us a bit more about the types of patients that were entered into this trial and the types of stroke that they had. We know that non-cardioembolic stroke makes up about 75 or 80% of the ischemic strokes. But there are many different etiologies of non-cardioembolic stroke. And tell me about the patients in here and which patients benefited from this therapy.
So if we look at non-cardioembolic ischemic stroke, the majority of those strokes as well are embolic. We just don't know a lot of the time where the embolus arises from. It can be an artery-to-artery embolus, small minor risk cardiac disease, or something else which causes thrombosis, and sometimes in situ thrombosis at the site of stenoses. Now, in traditional thinking, Charlotte and I, stroke neurologists, would not have thought that small vessel occlusion was tremendously thrombotic or embolic. But yet, when we look at these TOS subtypes, which is the traditional way of classifying them, we see a therapeutic effect in large artery atherosclerosis, but also in small vessel disease, lacunar infarcts. And I think, sometimes trials teach us about pathophysiology. What we're clearly seeing here is thrombosis is an important part of small vessel occlusions as well. And that's something we should pay attention to going forward. If we look back at previous data, we do know that thrombolysis is also effective in small vessel disease. There was a hint that thrombi were involved there. And as far as we can tell, comparing aspirin to placebo, there was an impact for small vessel disease as well. The other big category was stroke of undetermined etiology. So this takes up 30% of the spectrum of non-cardioembolic ischemic stroke. So these are ones where do cardiac investigations, vascular investigations, and we cannot decide where the source of this stroke was. We did try anticoagulation with rivaroxaban and dabigatran in separate trials compared to aspirin. We did not see a benefit. There wasn't a reduction in stroke recurrence, and there was a risk of hemorrhage. So this stroke subtype didn't have a treatment apart from aspirin until these data came along. So we see a good effect in stroke of undetermined etiology. I think, Jeff, collectively, these data are going to make it easier to treat stroke. You don't have to be an expert in stroke subtyping because we see benefit across all these subtypes.
And Charlotte, what about the patient characteristics? And somebody asked here and sent in a question about, did it make a difference what cardiovascular risk factors participants had, whether they had hypertension or diabetes, or did that affect it?
No, it did not affect the results either. And the proportion of hypertension, diabetes is what you're expecting in an ischemic stroke population. Interestingly, I think it really shifts probably also the way neurologists look at the risk of stroke recurrence, really leaving aside the vessel disease and maybe focusing more on the content. I think this is something we are learning also from a multidisciplinary perspective, is that even in the undetermined category, the vessel are basically normal. Otherwise, we would have decided that there was a specific cause. So it really shows us that whatever risk factors they are, the content of the vessel is much more important probably in the pathophysiology on which we should focus for the overall prognosis of our patient. The risk factor will be important according to how people are able to improve, and risk factors have an impact on the resilience of the brain after a stroke, but maybe not of the occurrence of the stroke, at least from what we see from this trial.
But I guess that there's another message here that for secondary prevention, we're talking about asundexian for secondary prevention, but secondary prevention also involves aggressive management of the risk factors, the
Absolutely.
blood pressure, the
Of course.
diabetes,
Yeah. And it's the same. When you include a patient in a study, they are very often very well managed in terms of other risk factors. So blood pressure is our main target, as well as diabetes and as well as lipid treatment.
and I don't want to get too far away from this study, but someone's asked you've got a huge win here with asundexian for secondary stroke prevention, but when the same dose of asundexian was evaluated compared with apixaban in patients with atrial fibrillation, there were more strokes with asundexian than with apixaban. So how is it that asundexian works so well here and it didn't work so well there? What is it, the dose, or is it the triggers for thrombosis? What's the explanation, or do we know?
So, we get this question a lot, and I think fundamentally what you have to remember is these are different diseases. So, what drives thrombosis in non-cardioembolic ischemic stroke is different from what happens in atrial fibrillation. People have speculated about roles of tissue factor in the left atrial appendage and various other things that would do it. The other difference between these trials, in addition to the disease, was the comparator. So in OCEANIC-STROKE, the comparator was placebo because the standard of care is antiplatelet monotherapy for the long term, usually with aspirin. In OCEANIC-AF, you had a very good comparator. So the DOACs, apixaban was the one used in that trial, are very effective in this condition. And then finally, that is a result with a dose of 50 milligrams per day. It's not clear if a different dose would have made a difference there. But one big lesson from the series of trials is we have to stop thinking about antithrombotics as being really the exact same solution for all these disease states. Prior to this sequence of trials, you might have started with treatment in atrial fibrillation, ACS, and if you didn't see an effect, given up. Clearly, what we know now is stroke has its own mechanisms and has its own benefit. Had we followed the usual paradigm, we would not have a treatment here.
Right. Well, I think we'll learn more about the dosing issue when we see the LIBREXIA-STROKE and LIBREXIA-AF trial results, because the LIBREXIA-STROKE trial is looking at 25 milligrams twice a day of milvexian, a total dose of 50 milligrams, same total dose of asundexian used in the OCEANIC-STROKE. And the AF trial is looking at 100 milligrams twice a day, so a 4 times higher dose. We'll see whether the 4 times higher dose does better there. And, what about moving on to that treatment window? OCEANIC-STROKE used a 72-hour window. LIBREXIA-STROKE is using a 48-hour window. Both of those windows are still fairly short to enroll the majority of patients with non-cardioembolic stroke. What can we expect for differences in that window, and how will we manage patients who present to us outside the window but would be still eligible for this trial?
So, and then, like Charlotte to comment as well, but so, it's not yet approved. However, as we're thinking about when it might be approved, subsequent to that, these decisions will be important. When you look at those cumulative incidence curves, it does not look like the effect is limited to a very short period of time. It looks as if the effect continues. So 72 hours was just the trial window, not to say the drug is ineffective after that. And certainly, in my view, there's a matter of equity here as well. Not all patients live close to a stroke center. Not all patients have great health care so that they can access expertise very quickly. Charlotte and I both work at stroke centers that encompass a population of millions of people. And if you live further away, if you live in a rural area, you should not be denied treatment simply because it takes longer to get there. So our thinking on this is once it's approved, we would be likely to use it outside that 72-hour window. What remains to be decided is how far outside we feel comfortable. Charlotte?
Yeah, and we are talking about preventing recurrent ischemic stroke that will happen a long time after the acute event. We are really going into a journey with the patient to reduce their overall risk for the future years. So even though we cannot treat them immediately within the first few hours after stroke, it's really building up also confidence and a strong relationship with the patient, trying to protect his or her brain for the next few years. So it's a longer journey than just 48 hours.
Yeah, and what struck me was, one, that the benefit was seen in all different stroke types, and including the lacunar strokes and the ESIS, where I wouldn't necessarily have expected an anticoagulant to work in that case. And the other thing was the reduction in the severity of the recurrent stroke. So not only you are less likely to have a recurrent stroke, but if you do have one, it's going to be less severe. And then the dramatic safety, the potential to uncouple thrombosis and hemostasis. And at first, when the trial results, I was wondering about the patients were stratified according to whether they received dual antiplatelet therapy for the first few weeks or single antiplatelet therapy. And I wondered whether the benefit would be in those who got single antiplatelet therapy. Tell us a little bit about that and about the benefit in both groups.
Thanks so much. So, and this is a subgroup analysis on the screen now. So whether or not you were initially assigned single or dual antiplatelet therapy, you benefited from the addition of asundexian, and the point estimates are quite close together. Now, looking at this, certainly stroke neurologists are tempted to think, well, maybe we don't need to use dual antiplatelet therapy anymore. Maybe we can dispense with the clopidogrel or ticagrelor and use aspirin and asundexian in the future. The issue, however, is this is not a randomized comparison. So we did not randomly assign people to single or dual therapy. This was determined according to guidelines by the treating physician. So what we can say is it works equally well, at least, whether or not dual therapy is there. And for now, I would resist the temptation to not use dual therapy if it was indicated. Um, Benefit we see is on top of antiplatelet therapy. And just, Jeff, to follow up on the issue of ESUS, so these emboli arise from somewhere. And now that we're extracting with mechanical thrombectomy, a lot of these thrombi, we can appreciate the diversity in the composition of the clot. There are different proportions of platelets, of fibrin, of red cells, and it changes in a single patient the longer it is there. So if you think about it, if you have worked out the right dose of an antiplatelet and something that affects fibrin, you can affect multiple sources of it. So ESUS, we weren't surprised at. And there was a hint of this in the COMPASS data. So with low dose rivaroxaban and aspirin, when we did stroke subtyping, we did see an effect on ESUS.
Right. And let's get into the safety a little bit more, because Charlotte, it really was the primary safety outcome was major bleeding, but we're also interested in clinically relevant non-major bleeding and even the minor bleeding, because minor bleeding or nuisance bleeding can lead patients to discontinue therapy. So tell us about the safety profile here.
I think this is really the big win also of such a strategy is that we really succeed in decreasing the event of interest without increasing the bleeding, and this is true for the major one, and this is true for the minor bleeding also. And as you said, it's very important for adherence to treatment. And of course, as a neurologist, I was also very interested in the rate of intracranial or hemorrhagic stroke. So what we call intracranial hemorrhage is bleeding in the brain parenchyma, hemorrhagic stroke, but it also adds subdural or more rarely extradural. It can happen spontaneously in elderly people or just after minor head trauma. And as you can see, both intracranial hemorrhage and hemorrhagic stroke were very rare events in the study, which was very reassuring. And also, I must say, I was a bit surprised because I mean, neurologists are always very anxious about bleeding. And you see that the data are very, very reassuring. Even in a population, I can't remember the mean age of our population.
68.
68. So those are patients who are at increased risk of intracranial bleeding. And it seems that we do not need to specifically stratify or personalize the strategy based on brain MRI or underlying chronic vessel disease to say that they will benefit from this kind of strategy or not. So it's a big win. And as you can say, it was also the impact on dependency so the disabling intracranial or the disabling hemorrhagic stroke were basically the same in the two groups.
And it's possibly
If I can add, just add to Charlotte's comments. So this is really very reassuring. Stroke patients, unlike patients with AF or DVT, are prone to cerebral hemorrhage. They're diseased blood vessels, and you don't see an increase in that at all. If anything, rates of hemorrhagic stroke, intracerebral hemorrhage, are lower with asundexian than placebo. Likely a chance finding, but it's remarkable to see that. And, on the right-hand side of the trial, what we want to make sure was that if you had a hemorrhage, that it wasn't worse on asundexian. We knew that they were less likely to occur. We want to make sure they weren't more severe, but we don't see that at all. So the chance of having disability is not increased when you're on asundexian.
Yeah, and I was just going to say, Charlotte, you showed us why factor 11 is less important for hemostasis than for thrombosis. And you could imagine in the brain, if there is a tiny leak in a vessel, the vessels in the brain are surrounded by tissue factor, and there's abundant tissue factor there that could induce explosive hemostatic slug formation. That factor 11 doesn't affect that. So that might be why it's so safe for the brain. All right. We have a question about, are there any particular baseline risk factors that would make you hesitant to put a patient on this medication, or others that would make you think this person would be a better candidate for this? In other words, for risk stratification, we saw that it didn't matter what the type of stroke was. Does it matter from the patient side, or if they're older, if their kidney function is less good, if they have hypertension? Does it matter from that perspective as to
That's, I think, one of the intriguing parts of those results, because the highest rate of risk factor you have, the highest risk of recurrent even is. So you want to invest on secondary prevention. So people with high blood pressure, diabetes, and poor lipid control, you will want to treat them more intensively. And on the other side, all those patients with undetermined source, the one you don't understand why they had a stroke, they rarely have such a high burden of vascular risk factor, but it still works. So I would say all patients with an ischemic stroke that is non-related to AF deserve today, tomorrow, the best treatment.
and in patients who have a non-cardioembolic stroke, some of these patients might have amyloid angiopathy as well. Would that be something that you would consider when you think about this treatment?
So it's a great question. So amyloid angiopathy is a microangiopathy of the brain, which is due to the deposition of beta amyloid inside vessel walls. These vessel walls become fragile, and people who have it have an increased risk of intracerebral hemorrhage, and importantly, a very high risk of recurrent intracerebral hemorrhage. We diagnose it based on the clinical history and also the MRI, which shows microbleeds. So in this trial, one of the questions we got from the neurologists who are investigators is, are we excluding CAA? And the answer was no. So we permitted people at a diagnosis of CAA, provided they hadn't already had a hemorrhage, into the trial. We know from phase 2, where we published, or presented and published the results of the MRIs. So everybody in the phase 2 trial, Pacific, had an MRI. We did not see an increased risk in people with markers of cerebral amyloid. We will be doing the same thing for the OCEANIC MRI substudy, but thus far, that's not an exclusion.
And that's very reassuring, isn't it? Because we're always worried about anticoagulating someone who has these microbleeds or has the amyloid angiopathy.
Yeah. And maybe I think also about risk factors and which kind of patients you will want to give this strategy to prevent recurrent stroke. What would be very interesting is also to see how it modify the accumulation of silent lesion on a long-term basis and the impact on cognition, because we know that the next challenge beside preventing clinical stroke is to prevent vascular brain injury and to promote vascular brain health. And this strategy, intensifying the prevention on small emboli in the brain, may also have an impact on the quality of life and dependency and cognitive function.
Sure. So let's spend a bit of time on the duration issue. And we talked about the window here. We've talked about baseline characteristics. What about the differences in the window for LIBREXIA-STROKE versus OCEANIC-STROKE, the 48 hours versus 72 hours? What might we expect with that difference And I know your crystal ball may be a little bit cloudy, but
So, if we think of these antithrombotic trials and secondary prevention, the shortest windows with dual antiplatelet trials, which were either 12 or 24 hours after symptom onset. When you have a very short window, you cannot include people who have been thrombolyzed or people who are requiring mechanical thrombectomy because you have to wait at least 24 hours after that treatment to use antithrombotics. So those trials included only minor strokes. They couldn't include ones which were larger. Um, with 48 hours, you have a chance for them, but not as much as at 72 hours. So, what a wider window does is it allows more severe strokes, more strokes after hyperacute therapy, at the sacrifice of some of the very early strokes that occur. So, in Oceanic, there are about 600 odd patients randomized in the first 24 hours. So, very dissimilar to the population in the dual antiplatelet trials. So we'll see what it looks like once LIBREXIA-STROKE is published. It's my hope that with 48 hours, they'll capture a lot of patients with more severe stroke who had hyperacute treatments.
so you would expect, though, because as you said, Charlotte, that the recurrent strokes are front loaded. So you would expect that there would be more strokes if your window is 48 hours than at 72
Yeah.
hours. And how do you interpret the time to event curves, Mike, where you see the curves really separating at about a month? Let's say what's happening in those first few weeks, and is that an issue that we need to consider?
So, it's a really good question. And part of it has to do with the thickness of the lines on the graph.
See if we've
So,
got something.
if you blow it up, what you'll see is, the curves start to separate about day 10 and are consistently separate by day 15. And we get asked this, you look compared to the dual antiplatelet trials where there's separation very quickly. What you have to remember is these are different populations. So here you have more severe strokes, and the median time of randomization was 50 hours. So this group has survived to 50 hours. In the dual antiplatelet trials, minor strokes who are captured very early. So you get that very early event rate. Um, if you think about the biology of the agent, no reason to suspect a delayed event. It's very rapidly absorbed, has an effect within hours. So we think this is just chance and the type of inclusion of patients and not the fact that there's a delayed effect.
And my last question about duration relates to, is this going to be a forever therapy now? Once you start it, are you going to continue it forever?
Very often, this answer do not really depend on doctors. It depends on payers. So we'll see in every country
Okay.
what will they
I
decide.
get
As a
that.
doctor, I will opt for a long-term treatment because the risk of a recurrent stroke doesn't decrease with time. You get older, your vascular risk factors are more present, so the risk remain the same at 5 years or 10 years.
Right.
And so it's just that we will need the data to prove that. But my
Yeah.
strategy will be long term. Yeah.
All right. So now let's move on to the fourth part of the symposium, which is focused on keeping up to date with best practices. How can we optimize our approaches to secondary stroke prevention now and in the future? And we know that this medication is not approved. We know how it works, and we're just putting together here a theoretical case that could happen in someone who is prescribed this drug downstream when it is approved. And how would we think about the management of this person, and what specialties are going to interact here to be involved in the management of this patient. So, we have someone here, an elderly person who has a non-cardioembolic stroke. She's receiving antiplatelet therapy for secondary stroke prevention. Let's say she's been put into this OCEANIC-STROKE trial, and she's been prescribed one of the medications, and now she's fallen and she's fractured her hip. The surgeon wants to take the patient for surgery. We know in patients with hip fracture that the sooner they go to surgery, the better the outcome, the lower the morbidity and the mortality. So what are we going to do, and how can we give this person the best care? So we know that if the person was in this trial, got randomized to asundexian, we would be able to tell by doing a activated partial thromboplastin time. If that activated partial thromboplastin time was normal, either they took their last dose long enough that it's cleared, or they were prescribed placebo. And if they're on aspirin because they're beyond the first 3 to 4 weeks, it's pretty simple, because then we're not worried. We don't want to stop the aspirin. The surgeon could take the patient to surgery. After the surgery, it'd be prudent to give at least a 4-week course of thromboprophylaxis. It could be with low molecular heparin. It could be with a DOAC. And then we go back to chronic care. What if the PTT was prolonged? What could we do? I think the emergency doc is likely to call up the hematologist and say, what do I do? What's going on here? And so there'll have to be education about the fact that this is a medication. It prolongs the PTT, that prolonged PTT is not associated with a huge increase in bleeding. Look at the safety data we've all seen. We might, if the surgeon's very worried, wait 12 to 24 hours until the PTT is normal, hold the asundexian, patient goes to surgery. They could start the asundexian the next day. We start low molecular heparin the next day. We start full dose anticoagulation on postoperative day 3. So I would not be hesitant. And then you could think about whether is the baseline aspirin enough for thromboprophylaxis. We don't know about the capacity of asundexian to provide thromboprophylaxis. It might not. But if you wanted to, you could add a low dose, low molecular heparin and prophylactic doses as well. So I think there's going to be a need here for a lot of education and management. So Mike and Charlotte, you're both involved in this trial. There must have been patients in the course of this trial who had falls and needed surgery, or who had to undergo procedures. Have you captured this information, and what will we learn from that?
So 12,327 people doing what people do. So they broke their hips, they cut themselves, all sorts of things happened. And we are collecting that data, and we will present it. The one thing to remember is it's a relatively small number of events, even in a trial this large, and we look forward to collecting more data as time goes on. A couple of things. So this case is really very instructive. So in the trial, and these were all patients who had stroke, just about all, 95%, we did not prohibit the use of prophylactic low molecular weight heparin. So our results are on top of that. So if you think you need it, please go ahead if the patient's on asundexian. One of the things that's going to be key is education of hematologists, and you will be getting, if you're a hematologist in the future, a lot of calls about elevated APTT. I personally apologize for that, but that's what's going to happen, right? Just because of this. It'll be from emergency physicians, surgeons, anesthetists, everybody, family physicians will be calling us to what this means. So that education will need to be phased out. In a case like this, and Charlotte has some experience as well, one of the important things where I think it would be important if you are called as a hematologist to involve the neurologist is if it is in close proximity to the stroke. So if this person was 3 days after the stroke, had just been randomized, there are concerns I have about hemodynamics, about rheology, about hemoglobin levels, all of those things. So I personally, for my patients, would like to be involved with the hematologist in this. The one thing that I have some concern with is overreacting. So that the APTT is elevated, something has happened. Let's say a fall with a bruise without a fracture, and people see that and start doing other things, putting in prothrombotic agents, especially in someone who has just had a stroke. I do have some concerns about that. And that's going to have to be communicated very carefully. And Charlotte, you've had some experience.
Yeah, exactly. A lot of my patients bike, and they seem to fail a lot from their bike just during the trial. It's always the same. But I agree. The rare cases where they did the hemostasis screening, a lot of people didn't know what to do and were very afraid. And this is also what is really interesting in working in improving this strategy, is that we are able to do it together. So right from the beginning, even during the studies, the hematologists from my institution and us were very much in collaboration. And I think we've been through this new agent modifying our perspective of hemostasis interpretation through direct oral anticoagulant. Remember, I mean, a lot of people were very afraid, and we had a lot of calls. You had a lot of calls, and at the end of the day, I think it's a great progress, and we are able to better work. And what I really think that involves a specific time of trauma or a necessity of surgery is that it increased the risk of ischemic stroke. So this is not the case of backing up because you're afraid. It's really the case of tailoring prevention according to the brain and the other characteristics. So it's time to collaborate.
Right. And I think what I've learned from you, Mike, is that, these patients are at high risk for a recurrent stroke, and that risk is front loaded. So if someone has some troublesome bleeding, I'm not saying serious, but troublesome bleeding in the first 21 days when they're on dual antiplatelet therapy plus this factor 11A inhibitor, it would be prudent to think about stopping the clopidogrel
Yeah.
as opposed to stopping the aspirin or the factor 11A inhibitor. And likewise, someone's asked here, and I was going to mention it too, is that if someone who's on the aspirin plus a factor 11A inhibitor presented it with, say, a ruptured viscus and needed urgent surgery, there's no time to wait for the drug to clear. What would you do? I would say to the surgeon, take the patient to surgery. You could use tranexamic acid to reduce the bleeding risk during the surgery. Most surgeons, or at least in our place, are using it anyway to reduce bleeding in all kinds of surgery. And I think that we've seen the low bleeding risk. We've seen with other factor 11 inhibitors that procedures can be done safely, even with more extensive factor 11 inhibition. So I wouldn't be too worried about the patient going to surgery.
Mm.
All right. Is there anything I've missed here that you would like to add before we just talk about the multidisciplinary care and anything that the audience would like to ask? Are there any other questions?
So
See if I have any other questions
put the
running.
questions into your phone. if there's a hand
Yes.
there, Jeff. That.
Currently, there's a recommendation for 325 milligrams aspirin to prevent recurrent stroke if you have large vessel 70% of water occlusion. With this, because those patients were included, would this make that recommendation obsolete?
So, Mike, what is the recommended aspirin dose?
So the current standard is 81 milligrams per day, irrespective of the degree of stenosis. So we do not recommend or prescribe 325 based on the degree of stenosis. In this trial, we used 81 milligrams throughout it. We have looked at stenotic vessels versus non-stenotic vessels. We don't see any difference in terms of the efficacy. So I would continue to use it. Look, if you look at meta-analyses of efficacy in stroke patients by aspirin dose, and remember, in stroke, we used to use 1,600 milligrams BID in the 70s when those trials were first done. If you look at that, what you see is not greater efficacy with higher doses. You do see increased risks of GI bleeding. So we've gone to 81 milligrams. There is data, by the way, in stroke supporting doses as low as 30 milligrams a day. But for a lot of reasons, including coexisting cardiac disease, we stick with 81 milligrams. So not a concern. If somebody, for some reason, was on 325 milligrams, apart from me asking why, I don't think I'd be concerned using ACE and Dexium.
Are there any other questions? I'm not seeing any popping up. Feel free to pop them in. If not, I'd like to thank you all for attending, and I'd particularly like to thank my two colleagues here. I've learned a lot from this, and I hope you have. Thank you very much.
This has been an activity published by Peer Voice.